concept of iPEDENDO has been there for quite some time, because we have been trying to solve problems in a easy fashion, so that we are able to really identify and evaluate complicated pediatric endocrine problems in an appropriate fashion. Number of approach pathways which will allow you to approach to a particular endocrine condition, manage pathways, calculators, diagnostics, therapeutics, and knowledge bank. So it's like, how does it work? We have got 31 approach pathways, which basically covers every condition that you will encounter as pediatric endocrinologist. We have got around 13 management pathways which cover the various possibilities. And when you talk about these pathways, they actually look simple when you solve them, but they are actually very complicated algorithms. So there are various weightages which are given to different situations, so that we want to select the lowest resources required to reach a diagnosis. So if you want to evaluate for growth failure, we would like to keep IGF-1 at the end. If you want to evaluate for some complicated calcium disorder, we'll keep calcitriol at the end. So the algorithm is designed so as to ensure that it is resource appropriate and the cost-benefit ratio is there in that situation. Then we provide personalized, prescriptionized management, and we'll discuss that all throughout that. Now, it basically is a very simple user interface. You just go to the disorder you're looking at, and then you answer a few questions. Yes, no, you will get the answer, and we'll go through about that in that situation. Now, this is available at both the Android as well as the iOS platforms. You can just go and download from there. All you have to do is to register. You will have a free access for 7 days for the entire app, in which you can look through. After that period, you will have access to specific things which are essential, like growth interpreter, like DK. A few of them will remain. Others are for a very nominal subscription in that regards. Now, many of these courses come bundled with their subscription. So if you take the course, automatically the bundle becomes from there. Just to go through a bit, the approach pathway basically uses evidence-based algorithm approach. And the way it is that you have to choose a condition. So suppose you want to approach delayed puberty in boys, you will answer a few questions, and all these are taking you to one section of algorithm. Now, there will be around 100 possibilities which are there, but you will reach, like in this case, we have reached 17 beta HSD deficiency. So it will end up at a particular diagnosis. Now, this is counterintuitive, but this is going to be quite helpful in reaching a diagnosis when you don't have access to expertise, which is not there everywhere. The management pathways similarly use the algorithmic approach. So like if you have hyperkalemia, it will ask the level of potassium, ECG changes, and it will guide you through with emergent management. So all your protocols are pretty much there. You don't need to go ahead and read it, and we give information specifically about doses also if it's required at that point of time. The diagnostic sections was developed largely by Dr. Riddhi, and it provides extensive information. So if you want to prescribe a test, it will give you all the information which is relevant, and every single test which is there in pediatric endocrinology is provided there, along with ranges which are difficult to find often in that situation. The Therapeutics by Dr. Sajili has around 64 drugs used in pediatric endocrinology. If you want to know about any in terms of doses, indications, contraindications, you will get all information about a particular drug. Like for desmopressin, it provides this information. So every aspect. Now, just a few words about pathophysiology. We all know that the TRH is the major regulator of the hypothalamic axis. TRH is the smallest hormone that we all know about. It has got 3 amino acids. It acts on the TRH receptor on the thyroid to produce TSH, which then acts on the TSH receptor to produce thyroxine. Thyroxine is a free hormone. It is not going to work at all. And this thyroxine, depending on body's requirement, is shunted between a T3 or a reverse T. And for that, we have got the monodeiodinase 1, which converts it into the active form, which is T3, and monodeiodinase part type 3, which will inactivate it into a reverse T3. Now, which situations will be associated with a greater inactivation of T4, the fetal period? Yes, and illnesses and sickness. So in those situations, you will have much more MDI3, your reverse T3 will be much more, and your total T3 will be less. Body is trying to go into a shell. When you are faced with an acute problem like a corona crisis, all of you want to do is, okay, survive. You want to just go into the shell. When you have got opportunity that things are fine, you start growing. That's the second stage. So when you have got favorable opportunity, your MDI1 will increase and you will have a higher T. What are the other situations in which MDI1 will be increased? Sign.
So in case of iodine deficiency?
Yes, and hypothyroidism. Any form of hypothyroidism, your MDI1 will be high. So now if you really think about it, if talk about primary hypothyroidism, what will be stepwise changes in TSH, T4 and T3? Narayan.
The primary hypothyroidism, TSH will be higher and T3, T4 will be low.
Yeah, so first thing will be
high TSH.
High TSH. Second?
The low T4.
Yes, and then last will be T3. So one investigation which is useless in overall evaluation, particularly for hypothyroidism, is actually T3, which is of not much use at all. T4 is a good thing to look at, but T4 of course is bound to the thyroxine binding globulin. So conditions which are associated with TBG excess, like pregnancy, estrogen exposure, those who are associated with deficiency will have low total T4, excess will have a high total T4 in that situation. Now T3 is also bound to TBG, but to a much lesser extent in that regards as compared to T4. So it's always better to do a free T4 in that setting. Now FT3 has to be shunted into the cell using MCT8, which is a transporter of thyroxine, and this then acts on the thyroid receptor. So you don't need to forget about that. I think the main thing you need to focus about is T3, T4 and TSH. Now when you want to do a thyroid function test, which tests are the most important? So if you want to order a test, which test will you order for somebody whom you are suspecting hypothyroidism?
Yeah, T4 and TSH.
For thyrotoxicosis? So what? FT4 TSH, and would like to do T3. Is T3 important in thyrotoxicosis? Yes or no?
Yes.
Why?
So this T3 is the main hormone responsible for its action.
And can you have a normal T4 and a high T3?
The T3 toxicosis is present.
So if you have iodine deficiency, the same MDI will increase your T3. So T3 is important more for thyrotoxicosis rather than hypothyroidism. So in terms of evaluation, you've got TSH. TSH has got 40% diurnal variation and 50% variation between the days. So what time should TSH be done? Do you think it should be done in the morning always? So what is 40%? When you say TSH is 2, it means that it could be anywhere between 1.2 to 2.8. Is that huge difference? No, because it's in the normal range. So if somebody is coming from a far off place, don't waste your saying that come again, get in the morning. It is not going to make a huge difference. You can do any time of it. T4, on the other hand, will depend upon when the drug was taken. So if somebody is on treatment, it should be done before the treatment is done. And it has got a TBG effect. And T3, of course, is affected by monodialysis. So if you have hypothyroidism, your TSH will go up and your T4 levels will go down, T3 will go down to a lower extent. While if you want to really do an evaluation for hypothyroidism, you should do T4 and TSH, or a FT4 TSH is good enough. In thyrotoxicosis, TSH will go down, T4 will go up, T3 will go up much more. So if you want to really evaluate, you do a T3, T4 and a TSH. Remember, FT3 is very unreliable. So I would never say to do a FT3. You do a T3, FT4 and TSH. So this is what the test you want to do. Now TSH levels, as we all know, vary with age. There is a huge jump at birth and then the levels really come down in that regards. This is because of the cold stress response which is there. And you can either do a TSH at cord blood or at day 3. In between, you should not really assess the TSH in that regard, otherwise the levels will be high. So what are the age limits you have to bother about? So in first week, the upper limit is 20, then it becomes 10 and 6. So action points you put on the right hand side, 40, 20 and 10, otherwise it's 20, 10 and 6. Until what age we consider TSH of 6, that is actually till 13 years of age. So very importantly, in boys or children, you want a higher cutoff of 13, which becomes relevant in that situation. Now, how do you interpret the thyroid function test? There is a log linear relationship between FT4 and TSH. As soon as FT4 comes down, your TSH should go up sky high. If your FT4 is low and your TSH is above 20, that would be what we call as primary hypothyroidism. But if it is normal, low, or up to 20, it will be inappropriately low for the level of FT4. This is central hypothyroidism. And once you diagnose central hypothyroidism, you have to do an MRI, you have to look at cortisol, you have to look at many other things before you start treatment. On the other hand, if your FT4 is low, your TSH should be 0. If your FT4 is high and your TSH is also high, there is a very, very rare situation of either a hormone resistance or very rarely TSH adenoma, which we have hardly seen. This is a very rare situation, mainly in older individuals you will see. So always interpret FT4 as far as the TSH level is concerned. Now, once you do a neonatal screening and you do a TSH levels more than 40, this basically you need to confirm and treat. This is congenital hypothyroidism. Levels less than 20, nothing to be done. And if you're doing an early sample, the cutoff becomes 34. If you have levels between 20 to 40, in that situation, you should repeat it after 2 weeks. And if the repeat levels are more than 20, you have to treat. While 6 to 20, you can consider evaluating and treating, and less than 6, nothing to be done. So basically, the TSH cutoffs are important. What about primary hypothyroidism? If your TSH is more than 10, you should treat. If the level is less than 6, nothing to be done. Now, if it is 6 to 10, you are in a dilemma, that is subclinical hypothyroidism. Look at FT4. If it's low, then treat. If it's normal, and if there are risk factors like TPO positivity, goiter, and growth failure, you may consider treatment. So treatment is mainly based upon your TPO positivity and the TSH level if it's between 6 to 10 in that situation. So we've got various tools which will help you in thyroid. That is in the form of the approach pathway for congenital and acquired hypothyroidism, pathways for thyrotoxicosis, solitary nodules. So all the pathways are there. And we'll now invite Dr. Pratik to sign. Sign to take us through the cases of these. And I think Sajili is also there. Okay. So Sajili, once she joins, she can join. Otherwise, we'll discuss at our level from that. Okay, so Sayan, you can take forward.
So a day 4 child by the neonatal screening was detected with a TSH level of 22. So according to the protocol already mentioned, this child was suggested for a repeat sampling on day 14 of life. It was again between the range of 6 to 20. So we repeated the sample on day 21. It again came to be high. So, but the FT4 was normal for the age. Further workup.
So what would you do in this setting?
So a high TSH on day 21 with the normal T4 is most likely a primary hypothyroidism. We have to run workup basically for the cause. And after the workup, we should initiate treatment without delay.
I think this is a very important message that you should not keep on waiting for a eternity. You have to wait till a time. So at 21, if it is 9, you may start treatment or not, but you should at least get an evaluation. Now, what you did in this ultrasound, as you can see in our algorithm also, it talks about the same thing.
Yes.
So when you looked at the ultrasound, it showed a
hemiagenesis.
So this, of course, is not a complete agenesis. This, of course, is not a dyshomogenesis. This is a minor variant. So this happened to be a hemiagenesis, and better to start treatment in that situation. Next case.
So the next case, a 20-hour-old girl with a TSH of 28.
What do you think in this setting, Narayana? Do you need to evaluate this child?
Okay, we can wait because 34.
Yeah. So day say 48 to 72 hours, we say about 34. So we should not draw at 20 hours. This is not significant at all. And this is the classical picture that you see.
So the repeat sampling for the same patient came up with a TSH level of 8.
So this is nothing to worry about.
A day 10 child with a TSH of more than 100. So as the protocol suggests, it's most likely a pathological cause on day 10 to have a TSH more than 100. The FT4 was 11 picograms per ml. The scan showed the patient to have no thyroid tissue.
So what do you think, Pratik, this is? Agenesis?
What scan was doing? This
Yeah,
is our
technician.
Technician scan, it can be agenesis. But
Can it be something else?
so there are very causes apparent thyrosis also we need to look into that.
Yes.
So the app guides us to the diagnosis here as well.
So if the TSH is very high and your scan shows no uptake, that is not the end of the story.
Yes.
Because you can still have a eutopic thyroid wherein the scan is not picking it up because either there is a TSH receptor blocking antibody, there is a sodium iodine imported effect, or a TSH receptor effect. So this is what is known as apparent athyrosis. So now if you look at it, it talks about likely apparent athyrosis due to maternal TSH receptor blocking antibody, TSH receptor defect, or sodium iodine imported effect. You start treatment, but it will be very vary that this may improve over time. Because if you have just a reversible phenomena, it may improve over time. So if you just put the basic information, you will get that interpretation coming out of it. Yeah. Carry forward.
So the ultrasound showed a eutopic thyroid, and the mother had hypothyroidism. So the next case, we have a 12-year-old boy with obesity. His height was 160 centimeter, weight was 70 kg. His TSH was 7.91, and the child was advised thyroxine by someone.
So again, do you agree with this?
So this is as per the case you already mentioned in the previous growth failure slide, that a high TSH in this case is the effect of obesity, not the cause.
Yes.
So we don't need to treat at this point. We just need to advise the child to reduce his weight, and we hope that the TSH will reduce. And so we can also look for other markers like goiter, TPO positivity, and then consider treatment.
Yes. So we looked at the TPO, which was negative. The other message is that please also do a FT4.
Yes.
Don't just do a TSH because then there is always a confusion whether you are in the right track or not. So if you had done FT4, which is normal, I would say okay, wait. So we got a TPO antibody which was negative, so this is nothing to be done in this situation. You carry on.
A 10-year-old girl came to us with complaints of poor concentration. She had a height of 136 centimeter, a weight of 34 kg, was euthyroid. The TSH was 2.4, but the T4 was low. So the question that arises at this point of time is the child hypothyroid? So as we already discussed, that T4 is bound to thyroid binding globulin and albumin. So only a complete T4 level is not enough, and we need to find the free thyroid level at this point. So the FT4 level came out to be normal. The TPO was negative, so no treatment was advised at this stage.
Yeah. So this basically means clearly that this is not a case of hypothyroidism. It is a case of TBG issues in that regard.
A 12-year-old girl presented to us with complaints of lethargy. Her height was 140 centimeter, weight was 36 kg. The free T4 was low, the TSH was high, and was advised thyroxine.
So do you agree with this?
So TSH low and FT4, so TSH high and FT4 low, so we should go for treatment.
TSH high and FT4 low. So what do you think is this case? TSH is 12 and FT4 is low. So is this?
Sir, the TSH is not appropriately high for the level of T4, as you mentioned in the graph. It should be sky high for any low level of T4. So this is, we have to work up for multiple pituitary hormone deficiency in this case.
So this is a very, very important case. Your FT4 is low, TSH is less than 20.
Yes.
So this could still be central hypothyroidism. So we have to obtain cortisol and MRI before we consider starting thyroxine. Otherwise, what will happen if you start thyroxine in this case, Narayana?
The cortisol, the patient going for shock.
Yes, because your metabolism of cortisol will increase, your 11 beta HSG2 will become more active, and cortisol will, whatever remaining cortisol is there will go, and the patient will go into shock. So definitely before you have starting treatment in this setting, you have to exclude a possibility of a
Yes.
underlying cortisol deficiency.
A day 12 child presented to us with irritability. Birth weight was 2.8 kg, but has now become 2.2 kg. So a weight loss of 600 grams in a 12-day-old child. Heart rate was high for his age, and he also had proptosis. The FT4 was very high, and the TSH was undetectable.
So what do you think is going on here?
So history, as per the mother's history, his mother had Graves. So the thyroid stimulating antibodies from the mother pass the placenta and come to the child. So, and as the child is a day 12 old, the action of the antithyroid hormones in this case must have gone off, and the effect of the antithyroid antibodies have presented at this point of time.
And the other big message is that she actually had a radioactive iodine treatment done 2 years ago. Now, despite that, the antibodies may remain positive. Yes. How long will they remain positive?
6 weeks. 6 months. 6 months.
No, in the mother. Despite, so she doesn't have that thyroid issue at all. But still, they may be there for 3 to 5 years also after radioactive iodine. So the big message is, otherwise the mother will give a history that she is on these treatment and all those things. Here, what is happening is that the mother had received a radioactive iodine treatment, but it was missed. And that caused this problem. So you have to monitor that very closely in that setting.
So this chart on the right shows that the half-life of 2 weeks for an antibody, but a half-life of only 2 days for the antithyroid drugs that are given to the mother.
So this is the transient thyrotoxicosis, which should improve. Now, if this child had persistent thyrotoxicosis beyond 3-4 months, what would be the possibility?
So TSH receptor activating, so the same would be present in the mother and the child.
Yes, so this is basically a autosomal dominant form of congenital thyrotoxicosis, and that TSH receptor is hyperactive. So that will be the rare possibility, very, very rare in that situation.
So 12-year-old girl presented to us with tremor. FT4 was again high, TSH was undetectable.
So what do you think, this is thyrotoxicosis or TSH adenoma?
So thyrotoxicosis, not a TSH adenoma, because the TSH is undetectable at this point of time.
And then you're seeing that FT4 is reasonably high, there is swelling and there are eye signs.
So swelling, no eye signs at this point.
So there is thyroid swelling but no eye sign. What do you think is the most likely possibility?
So even if there is eye signs or if there aren't any eye signs, the most likely case of thyrotoxicosis is a Graves' disease. So we have to do a thyroid scan at this point of time to differentiate between increased production or increased release.
Sure. So she has tremors and you did a thyroid scan.
Yes.
Now if you look at it, FT4 is high, TSH is low, eye signs are there, and in that case you can start out directly with treatment. Yes. And then based upon that, it assesses you that you require methimazole and then you follow up from there. So this is a clear-cut case of Graves' disease. The commonest cause of somebody who has got thyrotoxicosis with eye signs is?
So Graves.
Without eye sign is?
Graves.
Yes, so this is very important because Graves you have to exclude. If there is no eye sign, you have to do a scan. If there is eye sign and or swelling, you can stop the scan. You can go without scan also, which happened in this case. Yeah. Carry forward.
A 10-year-old girl presented to us with a thyroid nodule. The child was euthyroid at that point of time, was TPO negative, and was reassured and sent back home.
So just hold on there. So yes. If you have a patient who is euthyroid, hypothyroid, or thyrotoxic with a nodule, which has the highest risk of malignancy.
So the euthyroid status is, that is why we have to work up a thyroid nodule for.
So if you have hypothyroid, euthyroid, and hyperthyroid, which is the most likely to be malignant? Why?
TSH.
Yes. So if you have anybody whose TSH is more than 1, you have to definitely evaluate. So unless it's a non-suppressed TSH, that is very important, you have to do FNAC. But the higher the TSH is the growth factor for the thyroid. The nodule's chance of becoming malignancy will shoot up. So if you look at hyperthyroid, it will be very low, hypothyroid, euthyroid slightly high, and very high for hypothyroid. So euthyroid state is a risk factor definitely. So this was a wrong approach. We should have had done at least a FNAC. So any lesion which is larger than 1 centimeter should have an ultrasound done. And if the ultrasound features, we should do a FNAC. So what does the app suggest in that regards?
The child thereafter presented with rapid growth.
So yes, thyroid is there. Nodule is more than one, so
Yes,
it's featured. So then you have to do FNAC, and there will be a risk of malignancy, and you assess there. So anybody who has got a size more than 1 centimeters needs evaluation in that.